गुड इवनिंग सर।
Good evening, Gaurav. I've joined.
सर अभी 1-2 मिनट वेट कर लेते हैं, अभी पार्टिसिपेंट
Audible
कम है।
and visible, ना?
यस सर, यस सर। बस 1-2 मिनट और वेट कर लेते थे, पार्टिसिपेंट
ठीक
थोड़े
है
से
जी।
हो जाए तो फिर।
हाँ, बस ठीक है, शुरू करो। अपने आप ज्वाइन करेंगे।
Sir,
सर
shall
तो
I
कर दे
start?
सर। सर स्टार्ट कर दे।
क्या 8 बज गया एग्जैक्ट?
Yes, sir.
Yes.
यस सर।
How many people have joined? About
So there
20.
are 13,
No, 17 है, मेरे को दिखाई दे।
including the panelists. Yes.
सर
अच्छा, this is
17
including
टोटल है सर।
है, टोटल है ये?
Yes, sir.
हाँ सर, 4 तो अभी है सर। एक आईएपी से,
अच्छा,
एक आप, एक डॉक्टर मसूद और एक मैं।
2 मिनट और वेट कर लो, देन यू स्टार्ट, फटाफट खत्म करो।
Okay, sir.
सर कर देते हैं,
चलो।
19 टोटल में कर सकते हैं सर।
हैं?
सर टोटल 19 है तो कर सकते हैं, 15 पीपल तो लॉग इन कर लिए सर।
चलो आस्ता आस्ता शुरू करते हैं फ्रॉम द हिस्ट्री देन। चलो,
Okay, sir.
आई थिंक वी कैन स्टार्ट।
Okay, sir. So good
राइट।
evening, everyone. Uh, today's topic of discussion, today's case presentation is on a patient who is of a transfusion-dependent bleeding disorder and with a few complications.
Not
So we will,
bleeding disorder, it is a
I mean,
blood
yes, sir,
disorder.
blood disorder, sorry, sir.
Yes.
So patient D, who is an 18-year-old male child, is a resident of Delhi. He's a Sindhi by caste and informant was himself. So the chief
Remember,
complaints
you have
was
said two important things: resident of Delhi and
Delhi and
Sindhi by
Sindhi by
caste.
caste. Yes, sir.
Okay.
So coming to the chief complaints, he presented with the chief complaints of pain in bilateral lower limbs since 2 months, and he was admitted currently for routine transfusion and other supportive therapy. So the patient started complaining of pain in bilateral lower limbs since 2 months, which was gradual in onset and it was progressive. The pain was severe enough that he was unable to sit or stand, and it was partially relieved on oral medications. There was no history of trauma or fall,
Can you
no history
just
of
keep on explaining side by side? Why did you ask for history of this and that?
yes, sir.
Now
So
you have a patient who is complaining of pain in both lower limbs for the last 2 months, and it
yes,
is
sir.
progressively increasing.
Yes, sir. So I have asked for history of trauma, fall to rule out any fractures, joints
No,
swelling,
not
redness or
fractures.
warmth
Trauma
to
may
look
be
for
without fracture also. It may be a tear, soft tissue injury also. Not
yes, sir.
necessarily a fracture. Okay.
Yes, sir.
All right.
Yes, sir.
Go ahead.
Other than that, joint swelling, redness or warmth to look for
Okay.
any inflammatory cause of bilateral lower limb pain
Right. Fine.
like arthritis.
Yes.
There
Yes.
was, I asked for the history of fever to look for infectious causes. It could be
Mm.
osteomyelitis or it could be any systemic illness which can involve bilateral lower limbs. Then
Okay.
morning stiffness, rash, multiple joint involvement to look for autoimmune causes like
Yes.
rheumatoid arthritis. Then
Yes.
weakness,
Fine.
numbness, back pain, bowel bladder involvement to look
Mm.
for the spinal cord involvement and nerve
Mm.
compression that can cause bilateral lower limb pain. Transfusion
Absolutely right.
reactions
What
to
kind of transfusion reactions?
sir, there could be following transfusion reactions. There could be fever, there could be rashes and
But it is
anaphylactic
for last
reactions.
2 months. He's not been getting transfusion for 2 months.
Yes, sir.
What kind of
No, sir.
reaction do you expect? It could be delayed transfusion
Delayed
reaction.
transfusion
Yeah.
reactions. Yes, sir.
Delayed may be hemolytic or maybe non-hemolytic in the form of these type of joint pains or something like that. Okay,
Yes,
rashes.
sir.
Okay.
Yes, sir. Then there was no complaint of inability to bear weight or deformity, again for vertebral column
Okay.
compression
Fast.
fractures,
Otherwise, we'll be stuck
bones.
on history only. Okay,
Yes,
go
sir.
ahead.
Bone swelling to look for any malignancies or that can cause bone swelling, weight loss,
Okay.
appetite, night sweats for again malignancies and TB. Worsening pallor
Hmm.
or jaundice or high colored urine is to look for any acute hemolytic crisis.
Okay.
And chelation and transfusion history, because under transfused or non-chelated people can have increased risk of complications of bone-related complications like osteoporosis and delayed puberty or hypothyroid symptoms, because again a very important cause of osteoporosis would be hypogonadism or
But why are you thinking of osteoporosis? Who gave you this idea? He's complaining of leg pain and you are thinking of osteoporosis. What?
sir
There are
in
so many
a
causes of leg pain.
yes, sir, vitamin D deficiency could be there. It could be because of, sir, because in a long-standing transfused patient,
Hmm.
um, it is very likely that he might have a low bone mineral density, provided that he is, um,
Okay, you can think like that because since
yes,
he is
sir.
a very regularly blood transfusion on dependent on blood transfusion right from beginning, the likely diagnosis which comes to your mind may be associated with, which is commonly associated with bone problems
Bone
like
problems, yes, sir.
osteoporosis or
Osteoporosis,
osteopenia or something.
yes,
Okay,
sir.
fine. Next.
So the patient was evaluated on an OPD basis. A DEXA scan was done, and he was reported to have a low bone mineral density, for which he was advised 6 monthly injections along with blood transfusion.
Okay.
So the patient was diagnosed with a blood disorder that requires blood transfusion at 3 months of age. Since then, he undergoes regular transfusion every 15 to 20 days at Deen Dayal Upadhyay Hospital. The last transfusion was administered on 10th of May
You can
with a
say in
pre.
a hospital in Delhi, need not mention the name
Okay,
of
sir.
the hospital. Okay, fine.
Okay, sir.
You can, you need not, it's not good to mention any names in the history. Okay.
Yes, sir. Okay,
Last
sir.
transfusion was
So with the
administered on 10th of May.
10th of May, pre-transfusion hemoglobin was 8.5, and there was no history of transfusion-related reactions.
Okay. Next.
So the patient receives regular packed red cell transfusion every 15 to 20 days, and he also takes iron chelation, which is Deprasirox 1500 mg per day and Defripron 4 capsules per day. He also takes calcium
Capsulprone
and
is
vitamin D
available as
supplementation,
Dafriprone is available as
oral
tablets or capsules. It's available as
capsules.
capsules, 500 and 250 milligram. Okay, fine. So it is not available in India. It is not
Yes, sir.
available as tablet. Outside, it is available.
250 years.
फेरिप्रॉक्स के नाम से आती है बाहर वो टेबलेट होती है. ओके, राइट.
Yes, sir.
Bisphosphonate, how
So,
do you know?
moving forward, patient is,
No, go back. Bisphosphonate therapy, who told you this? When was he
um,
given?
sir, when he was evaluated and he was found to have a low bone mineral density on the DEXA scan,
He was
it was,
given some injection every 6 months.
yes, sir.
How do you know it is bisphosphonate?
Um,
Low mineral density, there are other injections given which are given 6 monthly.
sir, most
What
likely
is that?
because uh, the
Not bisphosphonate, other one.
um,
Denosumab.
denosumab, yes, sir.
And that is also given 6 months. So you can't
Yes,
say
sir.
which definitely it was bisphosphonate. Fine. Chalo. Never mention like this name of the medicines.
Okay,
Some
sir.
injection was given, though you don't know which type of, because they are both given at 6 months.
Okay, sir.
Bisphosphonate can be given monthly also, 1 month, three
Yes, sir.
monthly also.
Yes,
Different
sir.
preparations are available. It can be given oral also. Okay?
Yes, sir.
Chalo.
Okay.
और आगे.
So, patient is born out of a non-consanguineous marriage. There
हम्म,
was no history of similar complaints in family members.
ठीक है.
Both the elder siblings were carriers. The birth history was non-significant. He was a full-term normal vaginal delivery with a 2.6 kg of birth weight, no NICU stay. He
Okay,
achieved all milestones at appropriate age.
fine.
He was immunized as per IAP.
Yeah,
and he
this much
belongs to,
of history is enough for an 18-year-old. You don't have to
yes,
go
sir.
to the birth history, but consanguinity, of course, is important
Yes,
in
sir.
this. Okay. Belongs to
So,
upper middle class. Okay. Now
yes,
you
sir.
summarize the whole thing. Come on. Let's
Yes, sir.
summarize it. Then
So
you.
this is an 18-year-old male who is third in birth order, is
Hmm.
Sindhi by caste, resident
Sindhi
of Delhi.
bypass does what does it mean?
So there are some,
You are mentioned the diagnosis likely to be transfusion dependent thalassemia. What are the
yes,
other
sir,
conditions which require regular blood transfusion at this age?
at 3 months of age,
3
or
months of age are different conditions, and
yes,
now
sir,
going through every monthly or every 3 weeks or every 2 weeks up to 17, 18, 20 years. What are the conditions
yes,
where
sir.
you need regular blood transfusion? Back 3 months,
Uh,
what are you thinking of? If I say that
Sir, it would
he was
be,
when he was diagnosed at 3 months, then
sir, it could be because of reduced red blood cell production, or could be
okay,
because of increased red blood cell destruction. So if
okay.
it is reduced red blood cell production, then there
Hmm.
could be conditions like diamond blackfan anemia, or there could
First, you
be,
will mention diamond black fun.
no, sir. No, sir.
Then,
Relatively less common, but I am just,
hmm,
sir, trying to go by the
no, this
etiology.
is going by Google. Not, I don't want Google knowledge here.
So,
Come,
sir,
think of normal condition there. See,
given the, yes,
what are
sir.
the conditions presenting at birth who require blood transfusion?
Sir, aplastic anemia,
Aplastic birth पे congenital aplastic anemia.
sir,
बर्थ
congenital
पे आएगा।
dyserythropoiesis.
हम्म, वो भी लेट आता है थोड़ा, और it may present early also. So
Yes, sir.
within 6 months,
Bleeding, yes, sir.
see, hereditary spherocytosis may present,
Severe forms, yes,
but
sir.
severe form may present. Then CDA you are saying, but that is a rare condition, and only type 1 presents early. Otherwise, type 2 is a mild type and it presents later on as a mild condition. Okay. Think of hemolytic disorder, thalassemia,
Yes,
when
sir.
the child presents. Earlier, we used to say that 6 months to 1 year they will present. Now, with more awareness, doctors also being aware, if child is otherwise okay, there are no other obvious causes of anemia, then it is likely to be thalassemia or
Thalassemia.
other complaint, other things.
Um, Sir,
I
it could
say
be,
he is 9 months, 8 months. What are the other possible conditions?
um, sir, the patient, sir, again,
There's
it
so
could
many
be,
conditions.
yes, sir.
You can divide them in groups: hemolytic
Yes, sir.
condition,
Hemolytic
bone marrow
conditions.
failure syndromes.
Yes, sir.
Then you have storage
Reduced
disorders.
storage. Yes, sir.
Then you have infective causes.
CMV, torch infections could be there.
uh, or how do you rule out storage disorder with huge spleno? We have
So,
not come to that, so I will not discuss that. Okay.
yes, sir.
So these are the likely conditions which may present in first year of life and
Yes,
may
sir.
require blood transfusion. From the
Okay.
history point of view, if you see, there will be a family history of either splenectomy or gallbladder stone
Requirement of
involvement in case of
transfusions.
hereditary
Hereditary
spherocytosis.
spherocytosis. Yes, sir.
Okay, because it is a
Autosomal
autosomal
dominant condition.
dominant condition. So one of the parents might be having similar problem, recurrent jaundice. G
Yes, sir.
autosomal dominant this hereditary spherocytosis patient, they present at birth with severe jaundice also they may present.
Yes, sir.
Okay. Then you have other conditions like thalassemia, which gradually presents irritability,
Yes, sir.
feeding
At
problem, and all
3 to 6 months.
and there may be a family history of somebody receiving blood transfusion, but it is an autosomal
Autosomal recessive condition.
recessive disorder. Okay. Then other syndromes, bone marrow failure syndromes are there. But then infective
Yes, sir.
causes may never forget disseminated tuberculosis. You should mention always in cases of severe hepatomegaly that, but severe anemia may be presenting feature of malaria in an,
Yes, sir.
okay, they may present with it.
Hemolytic anemia.
And then hematological malignancy, though it's rare, congenital leukemia may also be presenting here. Then you have pure red cell anemia.
Yes, sir.
Okay. Then other,
Sir, Fanconi's anemia, where
okay, then
total
those conditions they have.
all the cell lines are affected.
No, they have bony problems also along with the anemia.
Bony problems are also there. Yes, sir.
Yeah,
Yes, sir.
visible bony problem. Okay, now coming to the conditions which you're mentioning at 18 years, 15 years, what are the conditions that may present with this?
Sir, it could be
With recurrent anemia, child otherwise doing well.
sickle
Common.
cell anemia could be there.
Sickle cell can be present.
Thalassemia,
Severe variety of sickle cell may present in
sickle cell.
infancy also. It may
Yes, sir.
present, but what are the, how you clinically differentiate a sickle cell from other conditions?
Um,
Sickle cell will have recurrent.
sickle cell crisis, the
Yes,
aplastic
crisis. We
and
know
hemolytic
occlusive
crisis,
disorder,
leg ulcers.
dactylitis, and
Yes, sir.
okay, swelling of the
Leg
joint,
ulcers are,
bones.
yes,
Yes,
sir.
dactyl it may present. So sickle cell, they don't generally they don't require regular blood transfusion like this. So number one condition, if a child is otherwise not having any other major problem, is thalassemia, which requires
Thalassemia.
regular blood transfusion throughout. What are the other conditions you can think of? Sickle cell, you have said okay at this age.
Um, Sir, enzymatic defects could be there, like
Yeah,
pyruvate kinase
they
deficiency.
are very rare. They present like
Relatively
this,
rare.
like congenital
Yes, sir.
dyserythropoietic anemia and then
Yes, sir.
enzymatic PKD. They are
Yes, sir.
those disorders you think only when you have ruled out other possible causes. You got the
Other
test
possible.
done and you find it is not thalassemic. Then you
Yes,
will
sir.
think of PKD and other conditions.
Yes,
Okay,
sir.
you don't think of them, but then you have other conditions like aplastic anemia, but aplastic
Aplastic.
will not have this type of regular transfusion and he will not have other symptoms like features of thrombocytopenia, aplastic, you will have leukopenia also. So they will
Yes, sir.
manifest with recurrent infection, bleeding, or something or the other, but they will not
Yes, sir.
have simple journey with regular blood transfusion. So the
Yes, sir.
main conditions that makes it isolated is thalassemia major.
Thalassemia. Yes, sir.
What is the other name for thalassemia major?
Sir, Cooley's anemia.
Now, nowadays, what do you call? Cooley was one who Cooley's anemia was in 1925 when he discovered described this condition. Nowadays,
Yes,
we
sir.
call it
TDT,
transfusion dependent.
transfusion dependent
Absolutely right.
thalassemia.
And the other variety is
NTDT, or
NTDT,
non-transfusion
non-transfusion
dependent,
deficiency.
which includes
Yes,
thal intermedia.
yeah, that's okay. Chalo. Or you have said that regular blood transfusion compliant with or to chelation, not having any, now having bilateral limping secondary to low bone mineral density associated with regular blood. Now we come to examination. Okay, go ahead.
Okay, sir. So
This
the
is an
patient was,
autosomal. You said Sindhi. Why
yes,
Sindhi?
sir. Sir, because there are certain castes where there is increased
Can you name
re-
4, 5?
sir, Sindhis, Gujaratis, Punjabis, um,
Bengalis, Gauds,
Bengalis.
Saraswats,
Yes, sir.
Jains. Now
Yes,
there
sir.
is no, because of intercaste marriage, there is no caste which is spared, but it is more common in Punjabi, Sindhi, Gujarati, Marwadis, and Gauds and Saraswat and all
Yes,
that.
sir.
What is the incidence I'm asking of thalassemia? How many thalassemia births take place in India in a year?
So
Roughly
I'm not aware of the figure.
10 to 15,000. Remember it. It's
Okay.
expected that we have somewhere between, according to the, what is the number of or percentage of people carrying thalassemia minor. They are also called traits and carriers.
Carriers.
Yes. Now, can you tell me the percentage?
So around 5%,
3 to 4%
3
on
to
an
5.
average in India.
Yes, sir.
Okay. That is the prevalence of thalassemia minor in India.
Carriers.
In this part of country, North India, which type of thalassemia is more common?
Uh,
Beta thalassemia.
HBE. Yes, sir.
No, beta
Okay.
thalassemia.
Beta. HBE is in
As
Bengal.
you, yes, eastern side of
Yes,
India,
sir.
Bengal, Assam. Then you go
Yes, sir.
beyond that, Myanmar. Then you have in Thailand, Hong Kong, all those Singapore, all those places. E is also very common, but
Yes, sir.
here we mainly see beta thalassemia.
Hmm.
Okay, चलो आगे चलो.
So coming to the examination, the patient was examined in a supine position after taking informed consent.
Okay,
Uh,
come. Yes, 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 yes. Carry
okay.
on.
So the vitals, the pulse rate was 88 beats per minute. The respiratory rate was 24 per minute. BP was 110 by 80.
Okay.
SpO2 was 98% on room air. Temperature was 90 degree Fahrenheit. Pallor was present. There was no icterus, lymphadenopathy, or edema. Coming to head to
Thalassemics, you
toe.
will find he's 18 years, 110 is good BP for him.
Yes, sir.
Generally,
Lower
thalassemics
BP.
have a slightly lower
Lower
BP
BP.
because of the vasodilated circulation.
Circulation. Yes, sir.
Okay, right. Next.
So coming to the head to toe examination, the hair, eyes, oral cavity was normal. There was no prominence of cheekbone. No malocclusion was seen in the teeth.
Can you
Facial hair
describe
was
hemolytic facies?
so there are prominent maxillary protuberances. Then there
Okay.
is protruding. There could be prominent teeth are there because of the
Yes, yes.
maxillary prominences,
Malocclusion of teeth बोलते हैं उसको.
malocclusion of teeth. Then there are
Depressed bridge of
prominent
nose, prominent
frontal
frontal.
and parietal
Uh,
prominences. And
yes. Okay. These
yes,
are
sir.
the main prominence. These that is classically described as thalassemic or
Thalassemia.
hemolytic facies.
Basic.
Prominent
Yes, sir.
cheekbone. All this
Cheekbones.
is because of what's the cause of that?
Extramedullary
Yes, extramedullary. Come next.
hematopoiesis.
Hmm.
So
Did you
coming to the
check
systemic.
skin? Why did you check skin for normal? No dryness observed. Why dryness? Do they have less sweat production? No.
No, sir.
Why
So
did you
iron
try?
deposition,
But what does it do?
hemoth,
See, iron deposition will give us different color to
blackish
the skin.
pigmentation. Yes,
What
sir.
is the type of pigmentation? What is the color of the pigmentation? Come on, fटाफट बोलो.
Brownish, brown to
No
black.
brownish. It is grayish black.
Okay. Okay.
It is a dark color, like we all have wheatish color, but
Yes, sir.
it is a different type of wheatish color. It is
Yes, sir.
grayish brown
Grayish color.
color.
Yes, sir.
So if you see few cases of thalassemia with this thing, iron deposition in it is because of stimulation of the melanocytes and as well as deposition of the iron in the skin
Iron in this.
directly also. Okay.
Okay.
So after you've seen lot of cases of thalassemia from the skin complexion and color, you can say easy is to match skin color with the parents or sibling if they
Parents.
are there,
Yes, sir.
because it
Yes, sir.
will be different from the family complexion.
Family complexion. Yes, sir.
Okay, next, go ahead. Chalo.
So coming to the systemic examination,
Yes.
per abdomen inspection wise, abdomen was soft, umbilicus was central, there was no visible scar, sinuses, there was no
Which
visible.
scar did you look for?
So
Especially if,
splenectomy scar could be
and
present.
one more on the right side could be because, or multiple small scars of laparoscopy, because some of them might need because of gallstones,
Splenectomy,
cholecystic.
cholecystectomy. Yes,
Okay.
sir.
Chalo aage. Yes.
Then on palpation, there was no hepatosplenomegaly that was palpable, abdomen was
Mm,
soft, percussion findings
mm.
were normal, auscultation-wise bowel sounds were heard, and genitals could not be examined.
Okay.
Then, coming to the serious examination,
Because he was
there
in the
was no,
ward and all that, you could not expose him there.
yes, sir.
Right.
Yes, sir.
It's a part of
So,
examination. Remember, you have to do in the exams.
yes, sir.
Yes. You
So
can take
the,
anybody along with you and examine. Okay. Okay. There was no
yes, sir.
precordial bulge and clavicle line. Okay. Now next. Any positive
The
finding
rest,
anywhere?
no, sir. No, sir.
Okay. Go ahead.
So this was an 18-year-old male with
Mm,
transfusion-dependent thalassemia since infancy. He is on
mm,
regular transfusions and chelation therapy and has
mm.
presented with bilateral lower limb pain. Examination revealed pallor with no
How much was
hepatosplenomegaly or delayed puberty.
hepatosplenomegaly?
So
Spleen
there
was
was no
how?
hepatosplenomegaly.
With no hepatosplenomegaly. Are you sure?
So, sir, only the mildly I could just palpate the spleen tip. Other
You
than
should
that,
mention if you
there
have
was
felt
no.
spleen tip. How can you say no? Be careful. Okay, I believe you. You done good
Yes,
examination. I
sir.
know you must have done everything. But remember, before you say hepatosplenomegaly, no hepatosplenomegaly, remember that generally they have hepatosplenomegaly, and especially if he is coming from a hospital where the hemoglobin was maintained low. You said he was maintaining hemoglobin 8.5. So generally they will have hepatosplenomegaly. Before you say no hepatomegaly, make sure that there is no hepatomegaly. Okay, right. Generally they have. You will have some hepatosplenomegaly, but there are many thalassemics nowadays we find with no hepatosplenomegaly because they are well maintained right from the beginning. Okay, then there will won't be any hepatosplenomegaly. He has delayed puberty. You are not examined genitalia. How can you say delayed puberty? You have not. Okay, he's 18 years. So delayed puberty is a history. How did you elicit history of delayed puberty and what is the definition of delayed puberty? Tell me. खाम खामे ऐसी चीजें लिख के don't invite problem for yourself. Okay? You lost connection, Vasudha. Hello, Gaurav.
यस सर।
Where is Vasudha? Gone.
सर उनका कुछ नेटवर्क एरर हुआ है, मैं बात करता हूँ उनसे, उनकी तरफ से इशू है सर। सर उनके वाईफाई से सिग्नल चले गए थे, वो दोबारा लॉग इन कर दूँ?
अच्छा ठीक है. Ah, yes, I can. Vasudha, you are muted.
Am I
Yes,
audible now?
yes, yes.
Okay. Okay,
So
sir.
we were discussing delayed puberty.
Yes, sir.
What is the definition of delayed puberty? Somebody has written in the question answer, I was just seeing, absence of secondary sexual
Secondary
characters
by
beyond 14 years,
nine
in which,
years.
no,
Sorry,
9 years is for
no, no, sir.
precocious, 8 and
Precocious
9 years
puberty.
for females and males.
Yes, sir.
Okay, that is for precocious. For delayed
Yes, sir.
puberty, you have 13 and 14. 14
14,
for males and 13 for
13 for
females.
females. Yes, sir.
Okay. And somebody has written that, as I told you, SMR should be mentioned for 18-year-old adolescents because they
Yes, sir.
have delayed puberty, they have hypogonadism. It is very essential for a child adolescent to mention the genitalia.
Yes,
But
sir.
I know you told me that there was some thing that some problem that you could not examine him, we
Yes,
give
sir.
it. But for exam purpose, you must remember that you have to mention. You can
Okay, sir.
ask somebody to come and stand and ask, take his permission or parents' permission and take. Okay, next. With skeletal deformities. What are those skeletal deformities which you?
Sir, they could be
Nini,
vertical.
which you have seen in the, you are giving summary of the case. Vasudha,
Uh,
you should give me.
so there was no skeletal deformity. I mean, there was no hepatosplenomegaly, delayed puberty,
No hepatosplenomegaly, delayed puberty, or skeletal
was
deformity.
skeletal
So
deformities.
his puberty was on time.
Yes, sir.
How do you know?
Um, Sir, there was facial hair, there was axillary hair that was present.
What time did they appear?
So sorry, I missed asking him the chronology of the
You have to
events.
ask. How can you
Yes, sir.
say? You cannot say. No, you can say that he is showing all signs of puberty. That is fine.
Yes, sir.
But
Yes, sir.
at what age did they appear?
At
You
what?
did not ask even.
Yes, sir.
You cannot. You must
Yes, sir.
mention.
Yes,
If
sir.
you are saying that there is no delay, you must mention.
Hmm.
Okay.
Yes, sir.
What about his facial appearance? Was there any sign of hemolytic faces? No.
No, sir, there were no hemolytic faces and
Okay,
the facial hair
I
was
believe
present.
you, and fine, perfect that you've seen. So probably he was a reasonably well managed child, that
Yes,
he
sir.
had puberty also, he had facial hair. Generally, children with thalassemia, they don't have facial hair, even if
Yes,
they
sir.
are well managed, and many of them will have delayed puberty
Delayed
also,
puberty. Yes, sir.
and hypogonadism also. Many of
Yes, sir.
them will have. But
Yes, sir.
luckily, your patient did not have
Yes,
any
sir.
such features. Okay, fine. He has on investigation, you found that he had reduced bone mineral density consistent with thalassemia associated osteoporosis. What is the definition of osteoporosis? Why do you say it is osteoporosis?
The osteoporosis is a lower bone mineral density, which
Okay.
according to the DEXA scan, we define it as when the mean score of the patient is less than minus 2.5 of the standard deviations. Uh, so, in this case, I would call it as thalassemia associated osteoporosis because there will be several factors contributing to it. First of all, that because of long-standing transfusion, iron chelation therapies,
Okay,
vitamin
we'll
D
discuss that.
deficiency.
In this, see, since your patient has got some pain, bony problem, did you examine his sitting height and standing height?
No, sir.
Why? You know, thalassemics can have,
Spine compression.
no, they have
Yes, sir.
short trunk.
Yes, sir.
So you must take in all cases sitting
Fine.
height and standing height.
Standing height.
Okay, remember
Okay,
this
okay, sir.
because their trunk is shorter
Yes, sir.
and their limbs appear longer
Okay.
than general. But this is what I'm telling you is seen in cases who are not well managed, who have severe osteoporosis, who have compression, cord compression.
Hmm.
That is okay. So osteoporosis, you are saying, is based on the diagnosis given by the DEXA scan
DEXA
that they
scan.
got. Okay. Can you go back to the examination history slides? Did you have any other findings related to? Okay, go back. Everything appears normal. No prominence of cheekbones, no malocclusion, facial hair present. Fine. Okay, I believe. Fine. Next, we go ahead.
Then following this, we have the investigations recently that has been done for the patient.
Okay.
So
Yeah.
the pre-transfusion hemoglobin was at 8.6 with
What do you
TLC of
think about the hemoglobin? Let's one by one now we'll talk. What should be the
the
normal hemoglobin maintained for the
9 to
thalassemia?
10 should be the average
Yeah,
pre-transfusion
9 to
hemoglobin should
10.5,
be.
9 point to 10.5.
Yes, sir.
Around 10, you should maintain the
Yes, sir. Yes, sir.
pre-transfusion. He was maintaining low pre. This is not
Yes,
recommended.
sir.
Why do you say that? What happens if they maintain low hemoglobin in thalassemia?
Sir, that could again
No,
contribute to the
you will see it will give them features of hypoxia, low,
hypoxia, low
increased
transfusion
increased
requirement.
erythropoiesis
Yes, sir.
by giving maintaining high uh, pre-transfusion hemoglobin. You are suppressing the bone marrow.
Bone
You are
marrows.
suppressing the extramedullary hematopoiesis. But if you are
Yes, sir.
maintaining low, all these will there. Then there is
Yes, sir.
decreased production of, by increased erythropoiesis, there is decreased production of hepcidin,
Erythropoietin. Hepcidin also. Yes, sir.
and that increases the intestinal
Iron only.
absorption of iron.
Iron.
So then, see, we say that those who are maintaining good hemoglobin, uh, they need not have any restriction in diet,
Yes, sir.
thalassemics.
Yes,
But
sir.
if he is maintaining low hemoglobin, he
Low hemoglobin.
must take precaution, take avoid iron rich food. That is one. And what else can
Hmm.
you do to suppress iron absorption in children?
Vitamin C supplementation.
That helps in iron absorption or suppresses the iron absorption.
Suppresses
Your
the
your speech, no, your voice is not
it
clear.
actually helps to absorb the iron.
It helps to absorb. Why should you give vitamin C extra then? We advise them to
So
take tea with every meal.
helps. Yes, sir.
Tea
Tea. Yes,
suppresses
sir.
iron absorption. Okay. When a newly diagnosed
Iron
case of thalassemia comes to you,
absorption.
there are few things you advise them. One is to get some tests done, nuclear molecular tests done. Fine. Then in that case, when do you start them on? What is the advantage of doing molecular tests in thalassemia? Two, three things. See, by
Sir,
doing molecular, you come to know the type of thalassemia, whether it's a very severe variety of thalassemia or milder variety of. You must have read in the books beta plus plus, or beta zero
beta mine.
type of
Yes, sir.
mutations.
Yes, sir. Yes, sir.
ठीक है? So if it is
Yes, sir.
beta 00 mutation, then it is a severe variety.
Severe.
Most of our Indian, we know today more than 350 mutations of thalassemia. Out of them, 64 are seen in India, and out of
Yes,
them,
sir.
95. Which is the commonest mutation of thalassemia? Tell me.
IBS 1 to 5.
Yes, that is a very common objective type question given in your exams also. IBS 1-5.
Yes, sir.
Okay. So we
1 to
start
5.
them once you have confirmed the diagnosis. And where else it helps us? If a child comes to you with a case after taking blood transfusion, how do you confirm the
Mhm.
diagnosis? By doing molecular analysis. There should be a
Yes,
gap
sir.
of at least 7 to 10
At
days
least.
from the last transfusion, because the
Yes, sir.
WBCs of that will interfere with this child's mutation analysis of the donor blood.
Yes, sir.
Will WBCs of donor blood, whatever filtration you do, but still you have some amount of WBC going on with the blood, so that will interfere. So Books write that you wait for 2 3 months and after
Yes,
that
sir.
repeat HPLC and all that. In practice, we have seen nothing works. It is basically either you want at supportive evidence is that you do the HPLC of parents. If both are minors, then it means they are likely to be this is child is likely to be thalassemia major if both the parents are minor.
Yes, sir.
That is an
Yes,
indirect.
sir.
Confirmation comes from this. And then secondly, next third point is that if the parents decide to go for a second child in the next pregnancy, it is essential for us to have the mutation analysis of the.
Mutation analysis.
Yes. Okay.
Yes,
So
sir.
you start them on transfusion once the hemoglobin drops to less than.
9.
No, you not read it. It is less than 7 on 2 occasions, 2 weeks apart, when you have excluded other causes of
Okay, sir.
bleeding or loss of blood or any low hemoglobin.
Okay,
Fine?
sir.
Okay. So you give them PRBC. They need only hemoglobin. They need only
Yes, sir.
RBC. So we give them.
Yes, sir.
So you remove by blood by this thing
Leukoreduction.
WBC leukoreduction. There are three types of leukoreduction. One is pre-storage. One is bedside. You must have seen those filters being
Yes, sir.
used. Bedside filtration, but preferable is pre-storage filtration in them before you store because it removes all the WBCs, so there is no release of pyrogens or cytokines, and it removes the intracellular infection like
HIV,
CMV. CMV, not
CMV.
is HIV intracellular infection?
No, sir. No, sir. No,
Then
sir.
why
Sir.
are you saying?
But sir, we do screen for the
Don't give
triple H before
wrong
the
answer
blood
if you are
transfusion.
not clear. Okay,
Yes, sir.
fine. And now, when first time when a child of thalassemia comes to you, he might come to you with a TLC count of 30,000, 28,000, 35. It is not actual TLC. It is because of the
Yes, sir.
nucleated
Increase.
RBC, which your, yes,
Yes, sir.
nucleated RBC, which the cell counter may count as TLC. Okay, you always
TLC.
ask for a
Peripheral
manual,
smear.
manual
And
or
yes, sir.
peripheral from the peripheral smear that count. Okay, fine. Your platelet count. He was splenectomized or no? No splenomegaly.
No,
No.
sir. He was not
Okay. No.
splenitomized.
No. No. Platelet count is okay. Next one. Okay. Go. You go ahead.
Sir, then the other routine tests, creatinine, GFR, blood urea, BUN, uric acid, sodium, potassium, were all
Okay.
within the
Bye.
normal range.
Fine.
The serum ferritin as of 10th of May was 2,234. So
Is
this
it
is the
high or
nanogram.
normal?
I've written it. Sir, ideally it should be maintained below 1,000.
1,000. Right. Nowadays we
So,
maintain it around.
slightly on the higher range, but
Yes.
1,000 to
No. Not on the
1,500.
higher range. What are you saying? You are saying opposite of that. We maintain
No,
it
sir,
on the
I mean
lower
to say,
side, around 500.
sir, I mean to say that this patient is having it on the higher side.
Yes, yes, yes.
Yes, sir.
Let's finish now the treatment part of ferritin, which is more important from your examination point of view. Okay, you have given him blood, which is pre-storage filter. Now, what else precautions you take to make sure the safety of blood? You give
Sir,
them stored
leuko
blood,
reduced
okay,
within 15
leukoreduced,
days of,
properly tested within less than
yes,
two
sir.
weeks old blood.
Yes, sir.
Okay, then
Checked
what
by two
else?
people.
Okay, that's very good. Okay, next.
The temperature should be,
Okay, that I'll
it
come
should be,
to. Then
yes, sir.
see, we have to do the proper screening of the blood for 5
Yes, sir.
diseases. It's essential: HIV, hepatitis B, hepatitis C,
HbSAg,
syphilis,
malaria,
no, and
syphilis.
syphilis and malaria. It is
Yes, sir.
mandatory by law. Nobody can issue blood in India without testing for these. So to reduce the window period, what do you know about the window period? What is window
So,
period
so
of the
between the
infection? Yes,
so
it is from the
entry of
time
the
of
organism and when the
it is
maximum
detected by the
infectivity.
test. To reduce
Yes, sir.
this window period, we are nowadays doing nucleic acid test.
Yes, sir.
That
Amplification.
is to read amplification test to
Yes,
reduce
sir.
the window period so that the
Yes, sir.
chances of transmitted infections are less. Then we to
Yes, sir.
reduce the transfusion reaction, you give them filtered blood, you give them properly matched blood to reduce
Yes, sir.
allosensitization. We match for
Yes, sir.
ABO system, B positive, A positive, O positive, or O negative. That ABO and RH you are doing D. Then RH you have C and E also. So
Yes, sir.
C, small e, capital E, and Kel. So five other
Yes, sir.
blood groups we should test. We give them because they are receiving recurrent blood transfusion. Now,
Yes, sir.
temperature about the transfusion, there is a rule of 30 and 4 hours.
Yes,
When
sir.
the blood is
Should
taken
be
from the
started.
blood, taken out from the blood bank, it should reach the center within 30 minutes. And
Should be
we always
started within
transport the
30
blood
minutes. Yes,
at
sir.
the temperature of 4 to 8 degrees centigrade.
In a ice
Okay,
bag.
in a
Yes,
not
sir.
ice, ख्याल रखना ice नहीं लगाते.
I
In
mean,
a
sir,
cool bag, nowadays digitally
cool
controlled
bag.
cool bags are available.
Yes,
Yes.
sir.
And then we don't warm the blood before giving that. We don't rub. Earlier, people used to put it in a blanket or
Yes, sir.
towel and warm. No need to warm. You hang the blood straight away because there are slow drops are going. Initially, you give them at 2 ml per
Yes,
kg
sir.
per hour, means very
Mm.
slowly for 15 minutes. Because most of
Yes,
the
sir.
reaction, if they have to occur, they will occur in first 15-20 minutes or half an hour. Serious reactions. After that, you increase the speed and give them at a rate of 5 ml per kg per hour. So, an average 15 to 20 ml per kg means per sitting, you give them blood, which
First
increase how much hemoglobin is
few
raised by one
15 minutes.
5 ml of blood pack cell raises how much hemoglobin in a child? 5 ml per kg increases by 1 gram. So we are giving them 15 to
Sir,
20 ml
every
per
5
kg.
ml per
Per,
kg, sir,
yes.
one.
Every 5 ml per kg gives 1 gram, raises by 1 gram. So if you are giving 15 to 20 ml per kg, you are increasing the hemoglobin by 3 to 4 grams. And it should be given at a speed of 5 ml per kg per hour. So the blood should finish within 3 to 4 hours. India is a tropical country, warm country. No? Temperature is generally high. So we should not leave blood outside for a longer time, more than 4 hours, because it will get hemolyzed. Okay. So each unit of blood gives how much? Huh. Come. Right. You are muted.
Yes,
Hmm.
sir.
Okay. So each
Each-
unit of blood gives them how much?
The 3 to 4 hemoglobin rises by 3 to 4 gram per deciliter after
Okay,
each
fine.
transfusion.
No, how much iron does it give?
200
Each unit,
milligrams.
2 milligrams. So there is no natural mechanism of excreting the iron. So we
Yes, sir.
have to take help of chelators, and there
Chelations.
are three chelators available
Yes, sir.
nowadays. Can you name them?
Sir, deferoxamine,
Hmm.
depracirox, and deferiprone.
Yes, defroxamine, defrosirox, and
Def
Defrijet. I think you
deferiprone.
can read about all this in the books. It's
Yes,
nicely
sir.
given in most of the books.
Yes, sir.
Okay, now we go ahead with this.
Um,
Next, your case. And so, the drug of choice is, I'll just briefly tell you in just 3 minutes, 4 minutes about the important points that you should remember about chelation. See, nowadays, the first drug of choice is
defracirox.
Defrosirox, which is available as a Sunra or Defrijet, and we give them about 20 to 40 in case of major and 14 to 20 case in case of Thal intermedia
Moderate.
or NTDT. We give them per day. It is a
Yes, sir.
long-acting drug. Half-life is more, 12 to 16 hours. So once a day dose is required. It has got relatively fewer side effects it effect lasts for 24 hours. And that is big advantage of this drug, and it is reasonably efficacious drug. Then
Yes,
we
sir.
have another, it is given orally. Then we have
Yes, sir.
another oral drug that is called
Defiprone.
Defriprone, which is
Yes, sir.
available as Calfer, which is given
Capsules.
in the dose of 75 to 100
75 to
milligram per
100
kg per
milligrams
day in
in three
three
divided
divided
doses.
doses. It has got a medium 4 to 6 hours half-life. So it is
Yes,
to be
sir.
given in 3 doses. Only problem is it causes
Of granulocytosis.
gastritis, yes, and joint pain in about 10 to 20% cases.
Joint pain.
But in 1%, it may cause agranulocytosis. So monitoring, CBC monitoring with every blood transfusion and with every episode of fever is a must. Okay, and they must collect the report also and check. That is the only thing. If you take precaution, then it's a very good drug. An advantage of this drug is that it is a small molecule, so it removes better iron from the heart, more iron chelation from the heart than the two other drugs. Okay, it's a
Yeah,
better
got it.
chelator of iron
Yes,
from
sir.
the heart.
Yes, sir.
That's a very big
Heart.
advantage of this. So whenever a child comes to us with cardiac involvement, we give them Defriprone always, if we can
Defiprone.
tolerate. Defriprone. And then
Yes, sir.
Desferal, which is injectable
Yes, sir.
form. It's a big
Injectable.
molecule, not absorbed orally, has a very short half-life. You can't give that as intramuscular injection or oral injection. It has to be given in the form of subcutaneous
Subcute.
injection
Continuous
mostly. But in severe cases, we can give a continuous drip
infusions.
of IV infusion. It's given in the dose of 20 to 50 milligram per kg per day.
IV
Here, at
infusions.
one point, vitamin C increases the excretion of iron by desferol. But the catch here is that
Iron.
you should not give
Yes,
vitamin C if there
yes.
is cardiac involvement. Okay, it is vitamin C is given in the dose of 2 to 3 milligram per kg per at the time of transfusion, not otherwise. If it's not taking on Saturday, Sunday, this desferal, we don't give him vitamin on that day. But vitamin D definitely helps in iron excretion. Fine. So this drug. So why I'm mentioning about that this drug has got long half-life, short half-life. See, iron is stored in our body in a bound form with transferrin. Okay. When storage of iron in bound form with transferrin is exceeded, iron levels are more, then what happens? Then the capacity of binding this iron is difficult, is exceeded. Vasudha, your connection is not there. Gaurav? Audible? So
Yes,
I
sir.
was telling about the binding capacity of iron is stored in our body
Yes, sir.
in bound form with transferrin. When this exceeds, iron levels are more, binding capacity is not enough, then free iron is released in the blood, and that is called non-transferrin bound iron. Okay, that's a very dangerous form of
Yes, sir.
iron.
NP.
That is the most
Yes, sir.
damaging. So to
NP.
have less if side effect of iron excess in the body, we must have a chelator present 24 hours in the body, so that this NTBI, which is continuously produced at a slow rate. See, if a chelator is present for 8 hours in the body, then 8 hours it will chelate iron, but 16 hours anti-BI, non-transferrin bound free iron will be produced. That will damage the
Yes.
different organs of the body. So a chelator has to be present throughout. So that's why I say that when you give desferal infusion, then it is only for 10 to 12 hours. So 10 to 12 hours it is not given, then anti-BI may cause problem. So best drug that way is defroxirox, which has got long half-life and is present for 24 hours. Okay, clear? Right. Hello? क्या इसका तो Sudha? So
Yes, sir.
we have briefly discussed transfusion and chelation. Now we go to the complication part which your patient had. Come on, tell me about the.
Yes, sir.
Go to the next slide. If it is not,
Sir,
you
is my
cannot
screen
project.
visible?
No, it's not visible at. Yes, it is visible. So we go ahead. Now leave this
Okay.
genotype and all this. This is a very complicated slide. There's no need to go for this. Okay, next.
Yes, sir. Okay, sir. So, sir, like a lot of
15.
complications we can
Gaurav,
see.
Gaurav, we'll take.
Hello.
Gaurav will take another 15 minutes because there was a lot of disturbance in between.
Okay,
So
sir.
next,
Okay.
next 15-20 minutes, we'll discuss the bone disease in thalassemia. Now, come.
Yes, sir. So there could be osteoporosis,
Your
fractures, spinal
voice is
deformities, nerve
breaking.
compressions.
Yes.
Sir, I'm very sorry about it. It's a very
Okay.
unstable internet connection today.
Next time, make sure that you have good
Yes, sir.
connection. Okay.
Yes, sir.
Fine.
So, sir, osteoporosis, as this chart is from WHO, normal bone
This
mineral
is
density.
for, wait a minute. This is for adults,
Yes, sir.
minus 2.5. No, this is, you have written bone osteopenia, low bone. This is -1 to -2.5 or
Yes, sir.
2.5 standard deviation below this thing. Okay. This here you are taking, there are two scores that you take in
We have,
DEXA scan.
sir, T scores and Z scores. In T
What do you
scores,
mean by T score?
sir, in T score, we compare the bone mineral density with healthy young adults, and this is done
Yes.
for postmenopausal women or who are more than 50 years of age. So if a T
Yes.
score is more than minus the
See,
same
in our
deviation.
body, maximum bone density or deposition takes place in our bone when we are adolescents and young adults. In
Yes,
children,
sir.
it is low. And after, when you reach the middle age or later age, there is gradual decrease in
On.
bone density. That's why you
Yes, sir.
compare with a young adult
Yes,
T
sir.
score.
Yes,
Okay,
sir.
then you are given rightly this. This is
Sir, in
actually more than nahi likha karo. It is less than minus more than -1, -1 to 2.5. Okay, you have given correctly this thing.
yes,
And
sir.
Z score is with age
It
and
will
sex
sex
match.
match controls.
Yes, right. So in
So,
children, we don't say osteoporosis as such is the
yes, sir.
definition, but on the basis of DEXA scan. But what is the definition of osteoporosis in children?
Sir, low bone mineral density
Okay.
below minus 2.5 standard deviation of
For
Z
children, they
score.
take -2 Z score. For Z
Okay, sir.
score, they take -2, and
Okay, sir.
it is with the fractures. with
Okay,
minimal
sir.
trauma. Okay, minimal trauma, fragility fractures बोलते हैं ना. So let's complete the definition of pediatric osteoporosis is the presence of either it is one or two history of one or two compression, vertebral compressions.
Fragility
No?
fractures.
Yes. Well,
Yes,
one
sir.
or two vertebral compressions or long bone fractures. Two
Yes,
by
sir.
the age of 10 years and three by the age of 18 years. That
Okay,
is the
sir.
classical definition given by this for pediatric this thing. But by this less Z score, you get an idea that child's bone mineral density is less and he is very prone to osteoporosis,
Fracture.
fractures. What is
Osteoporosis. Yes, sir.
fragility fracture? Well, how do you consider this
Uh,
as minor trauma he had or major trauma? How will you consider?
um,
Fragility fracture is basically a fracture with a trivial trauma. But
Trivial
you
trauma.
consider
Yes, sir.
standard definition of that is that when you have fracture from a fall which is less than your height, like for a
Okay.
5.5 feet person, if he falls below that 4 feet and he gets a fracture, then it means a trivial
Trivial.
fragility fracture for him.
Okay,
Okay.
sir.
What is the
Okay.
difference between osteomalacia and osteoporosis?
The osteoporosis is low bone mineral density, and osteomalacia is uh, both mineral and the collagen, the elastic part. Both of them are
With
lower.
osteoporosis, see, the bones become, see, there is no loss of volume,
Yes, sir.
but bone become very porous
Yes, sir.
and brittle. There is
Yes, sir.
thinning of the cortex. With osteomalacia, what
Yes, sir.
happens? There is less deposition of calcium. It is because of vitamin D deficiency,
Yes,
you
sir.
know. So
Yes,
in
sir.
grown-ups where growth is complete. So it is less deposition of that. It is
Okay.
less hard.
Okay.
While on the other side, osteoporosis is very hard and brittle bone.
Brittle bone.
That's why it breaks very easily.
Okay.
Okay, next. Come.
So,
How do you
sir, we will,
diagnose?
sir,
How do you diagnose? See, it's a
sir,
very
based on the
common problem.
clinical
We
profile.
say that almost there are different papers saying different, but you can say more than 50% of thalassemics are either osteoporotic or osteopenic. Fine.
Yeah.
What are the so osteoporosis can be congenital or but not
Acquired.
for I'm not talking about thalassemia at present. Just osteoporosis, you are given definition. So we divide it in secondary. The cause of as thalassemia as a cause of osteoporosis is secondary.
Yes, sir.
But osteoporosis can be primary also.
Yes, sir.
क्या होता है वो एक कंडीशन बता दो मैं आगे और कुछ नहीं पूछूं
Um,
osteogenesis
Imperfecta. Yes, sir.
yes what are the other features of osteogenesis imperfecta
Blue sclera is there.
yes very important rest all are there easy bruising and
Yes, sir.
all that means fragile skin then you have joint laxity you seen that
Yes, sir. Yes, sir.
classical book given in the increased
Yes, sir.
joint flexibility. That is
Yes, sir.
osteogenesis. Then there is a condition called idiopathic juvenile osteoporosis. That's also congenital. But we'll be talking causes of osteoporosis occurring in thalassemia. What are the causes? What are the factors causing it? One
Sir,
is
so,
ineffective erythropoiesis, bone
yes,
marrow
sir.
expansion. Then
Yes,
severe
sir.
anemia, increasing
Yes, sir.
osteoporosis. What are the other causes?
Sir, iron overload, the iron
Yes.
toxicity in itself,
How does the iron
hypogonadism.
overload cause this thing?
Sir,
Iron overload दोनों
will
तरफ से खराब करता है. It increases osteoclastic activity and reduces the osteoblastic activity.
plastic activity. Yes,
Yes,
sir.
it damages from both sides. Or
Sir, low levels of vitamin D.
Yes, vitamin D also low level cause that. Then what are the other factors?
Um, Sir, hypogonadism.
Yes, very important.
Yes, sir.
Delayed puberty and hypogonadism, hypothyroidism, hypoparathyroidism, then you have diabetes, then
Hypopituitarism.
growth hormone deficiency. All these factors contribute to this. और क्या होते हैं बोलो?
Um, Circulation toxicity,
Yes,
especially
chelation to
deferoxamine.
defrijet,
Yes, sir.
defroscamine,
Yes, sir.
desferal. It causes
Desperal.
something rickets-like picture one, and
Yes,
then
sir.
it can cause
Flat
compression of the
vertebra.
vertebrae. What is that called?
Platyspannus.
Platyspondylus.
Platyspondylus.
Okay, and then it causes. See, this is one condition where a person can lose height. There's no
Yes,
other condition on this earth where a person can lose height because
yes, sir.
there is flattening of the vertebrae. They actually lose height when they grow old and they are on chronic this thing. This is the side effect of Desferol sometimes. Then
Yes,
what
sir.
is the bony side effect of Calfer?
Um, Sir,
Hypoplasia of the
hi,
lower end of ulna.
radial.
That has
Okay.
been seen. But otherwise, there are no other side effects. And similar, and
Arthralgia is
defroxamine is
also.
reasonably safe. Defroxamine is reasonably safe. Okay. Okay. Then next we go ahead. Okay. Or bolo?
Sir, then there are a few general measures for management of osteoporosis in case of
नहीं नहीं नहीं
thalassemia.
पहले तो अभी तो कॉजेस पे ही नहीं आए हम अभी तो पूरे कॉजेस करो ना
Okay.
देयर
Uh,
न्यूट्रिशनल डेफिशिएंसीज
yes, sir. Low
ओके
levels of vitamin D.
हाँ दे मस्ट टेक दीज थैलेसीमिक्स मस्ट टेक डाइट गुड इन कैल्शियम then zinc
Hmm.
deficiency.
Hmm.
Okay, all these contribute to the. So there are so many. Then activity.
Yes,
See,
sir.
because some children, because of some problem, may get bedridden. Then it
Yes,
also
sir.
causes the outbreak. Then smoking in adolescents in thalassemic, smoking and drinking also may be there. So we have to tell them to stop. Then
Yes, sir.
regular exercise, walking, these are all factors. If they can contribute to the development of osteoporosis, but if you avoid them, then they become helpful in preventing the osteoporosis. Okay,
Yes, sir.
how do you evaluate for the osteoporosis? Okay, you do
Sir,
the calcium level
routine blood
and
test, vitamin D,
yes,
calcium,
yes,
um,
or
uh, DEXA scan for the diagnosis,
yes, that is the
ferritin.
one thing. That is one scan which can be done, which is generally done. Can be kya? What is this is the only scan which is generally done all over because it is not very expensive. It can be reproduced and it's easily available nowadays in most of the places. What do you do in that scan?
Sir, it is a dual energy X-ray absorptiometry, as
Yes,
DEXA stands
that
for.
was the
So,
DEXA.
yes, sir. So that there are
At
four
what
common
place do
sites:
you find this? You do it at spine level.
hip, hip,
L1 to
spine.
4 hip
Yes,
femoral
sir.
neck करते हैं generally.
Yes, sir.
Hip
And
no, spine and femoral neck are important.
yes, sir.
Lumbar spine is L1 to L4,
L1 to L4. Yes, sir.
not L5. ख्याल रखना.
Yes,
Why
sir.
do they
Because
avoid L5?
so because the iliac bones from the
Yes,
sides
iliac
will
bone will
interfere
also, when
with
you
this.
take the section, they come and
Yes, sir.
interfere with that. Okay, that's very good. And then you do for whole spine, whole body also. That should
Yes,
be
sir.
considered. Okay, then you explained very rightly T and Z score. Okay,
That's
next we
good.
go ahead. Sorry, next. और क्या करोगे?
Um, Sir, we will uh, analyze the iron overload in the body by doing the ferritin or the MRI T2
Okay,
star
yes. So you will try to
uh,
reduce the iron load in the
iron
body.
overload.
You will keep good hemoglobin in the
Yes, sir.
desired range. So that these
Yes,
two
sir.
factors. Ask him to do exercise, take good
Exercises.
diet, take vitamin D.
Yes,
Nowadays,
sir.
we advise that all thalassemics to take reasonably good amount of vitamin
Vitamin D.
D every day, 1000 international units, and calcium also we give them. They should take calcium, high calcium diet. I advise, I hope others are also advising like that. 2 glasses of milk for a thalassemic child every day
Mhm.
they should take. Okay, that will suppress iron absorption. Also, we know milk suppresses iron absorption. Secondly, calcium, good source of calcium. They should take calcium tablets also when they grow little older. Fine. Okay. So DEXAs you are done, and there are some other tests which can be done, but we generally don't do. There are some markers of this osteoclastic activity, some markers of osteoblastic activity. They can be done, but normally they are not available and they are only for the research purpose. Similarly, you have PQCT, that is peripheral quantitative computed tomography. Yes.
Okay.
Okay, that is also done for research purpose. That is also quantification of bone density only, actually. It is,
Okay.
but it is not done routinely. We do same DEXA scan as you have mentioned.
Yes,
Okay,
sir.
so what else will you do? You will get the calcium done, corrected, vitamin D corrected. Okay, if there is hypoparathyroidism, then you give high
Yes, sir.
dose of vitamin D, or you can give 125 hydro.
PTH supplementation.
Yes. Okay. Right. Or then
Mhm.
how do you
Sir, we
treat
will
further?
evaluate. So
Hmm.
for treatments, I will take general measures like to do adequate transfusion, chelation,
Okay, that's fine. We
exercise.
have discussed that. Now we come to
Yes, sir.
how do you treat?
Pharmacological.
How do you
So for
treat low
pharmacological
bone
management,
mineral density in a child with thalassemia? You don't have any medicine to treat a child.
yes,
All
sir.
these medicines, but we will, I know you will talk about, they are all recommended for grown-ups only, no?
Adults. Yes, sir.
Yes, but off label, we have used these medicines in
Yes, sir.
children also, cautiously monitoring them carefully. So, what is the first line treatment of this low mineral density is
So
by reducing
bisphosphonates,
yes, they reduce the osteo,
resorption,
yes,
class, activity.
osteoclastic activity.
Yes, sir.
So, what are the different types of bisphosphonates available with us?
So we have alendronate, farmindronate, zoledronate.
Alendronate is oral and it
Yes,
is
sir.
available in the dose. How do you give it?
Sir, I think once
70 milligrams or also per week or 10 milligram per day. The only
per day.
problem of giving this is we have found that in
Yes,
thalassemia it is
just
not that effective. But the problem is that once you take this with lot of water, you, child should not be, the person should not be
GARD.
allowed
Yes, sir.
to lie
Sit.
down.
Yes,
Yeah,
sir.
they have to be erect.
Yes,
Now,
sir.
other bisphosphonates, you tell me.
Sir, zoledronate,
Hmm?
which is given as
No,
3 to 6 monthly.
pamidronate was one which was
Pamidronate.
used earlier. Zoledronate,
Yes, sir.
hmm, how does it? Again, the same prevents ball, but it
Yes, sir.
enters the bone actually, matrix.
Yes, sir.
So it reduces the osteoclastic activity, but they get
Yes, sir.
deposited there. It has got a very long life,
Yes, sir. So that is why it is given as 3 to 6 monthly
three to
injections.
6 months, or sometimes people give it yearly also. And what is the dose of that?
So zero point 0.1 to 0.3 mg per kg.
Yeah, somewhere you will find 0.25, point zero zero point zero two five, 0.05, 0.01. All these various doses are given, but
Mm,
generally for adults 4 milligram, good
4
uh,
milligrams.
weight adult, 4 milligram is enough to be given every 3 to 6 months, and but not for more than 2 years at a time.
Mm.
Why do you avoid giving for more than 2 years?
So because of other adverse effects like renal
Yeah,
toxicity, osteonecrosis of
you make
bones of the
sure
jaw.
any child who is taking bisphosphonate, you make sure that his calcium is
Serum
normal because
creatinine.
of osteoclastic. In fact, for
Yes, sir.
all other this thing, bone marrow improving agents also, you make sure the calcium is normal, vitamin D they are taking adequate, and their renal functions are normal.
Normal.
Okay. So the main side effect is that in long run it may cause
Osteonecrosis of the jaw.
osteonecrosis, but we have not seen in children. People have used zoledronate in children, bisphosphonates in children, but they have not found it in children, not
Yes, sir.
commonly seen. So we can give it also use. In fact, it is the first line treatment for low mineral density or osteoporosis. Okay. Now
Yes, sir.
next, which other drug can you use?
Sir, monoclonal antibodies like denosumab.
Denosumab. Yes, good. And it is recently was available. But remember, this is not, I think it is not FDA approved for thalassemia. But
Yes,
off
sir.
label, people have been using it, and it is a reasonably safe drug. What is the problem with this drug? What is the dose? It is given as a 60 milligram subcutaneous injection. What is the problem with this drug?
Subcutaneous solution.
Huh?
Cost.
Cost. Cost is important. And then, see, it effect does not remain longer in the body. The moment you stop giving
Yes,
it,
sir.
within few days, its effect will go. So
Yes,
there
sir.
is a rebound osteoporosis after. So what you do, you continue with bisphosphonates once you have discontinued.
Okay.
You may continue with low dose of bisphosphonates after that. Okay, that was about the denosumab. Then other drugs you know of? Have you read
Um,
any other drug? Tell me.
sir,
They are called
PTH
osteoanabolic drugs.
analogs.
They increase the osteoblastic activity. What are those drugs?
Um, strontium. Um,
Yeah, sclerostin antibody. Oh, छोड़ो, nobody uses
PTH
that.
analogs can be used, sir.
Yes, teriparatide.
Teriparatide can be used.
Teriparatide, though it is again not FDA approved for children.
Yes, sir.
Orthopedics people like it more because it helps in healing of the fractures.
Yes, sir.
It's more oriented towards fracture. That's why
Yes,
probably
sir.
orthopedics people like it. So it is given as 20 microgram injection every day.
Okay.
It's quite
Yes, sir.
expensive and traumatic because the injection is given every day. What else? What is the other problem with this?
Um,
I think this
I
is the
think so.
drug.
This carcinogenic.
No, osteosarcoma was once sometime associated with it.
Mm,
That's why they don't like this drug. But that's not a common side effect. Okay.
yes. Yes.
So now we have discussed about the three. The
What
drug of
another thing?
choice is drug of choice is bisphosphonate.
Bisphosphonates, zoledronate.
Avoid
Yes, sir.
smoking, avoid drinking, regular exercise, regular chalte raho. That is the only message that you should give to these thalassemics. Don't rest unnecessarily. Chalte raho. That is the thing that we want them to take plenty of calcium, take plenty of vitamin D, and they must take vitamin D supplements like we give to all our children in the ward. And then
Yes,
what
sir.
else? So that helps them recovering. But this process is not that fast that you give them these bisphosphonates and within 2 weeks or 4 weeks their osteoporosis goes away. It takes a very long time. That's why we have to use these medicines for long time. Okay. And whenever you are giving these medicines, you must monitor them for calcium excretion in the urine also. What
Yes, sir.
else? Do you want to, anybody wants to ask anything about this thing, osteoporosis or all this? Anything about thalassemia? Anybody can write in the answer question box. No, there are no new questions. Do you have anything about the newer? Let's discuss, because you
Yes,
may
sir.
get a short note on newer therapies in thalassemia. I told you to prepare that. Right.
Yes,
That's
sir.
good. Good. There are two,
So
three drugs. One is the gene. And see, on paper, gene therapy appears very simple. There is a defective gene.
just
Use
edit it
some
or add it.
agent to
Yes, sir.
take your corrected gene to that place and correct it and come out. No,
Yes,
it's
sir.
not
Right.
that easy. They are
Yes,
using
sir.
those vectors as lentivirus or retrovirus. They are
Yes, sir.
inactivated viruses. They go inside the body, go to the bone marrow, replace that defective gene. On paper, it appears very simple, but
Yes, sir.
practically, it is a very difficult thing. Gentiglow is of, I think, Bluebird company. Yes, Gentiglow of Bluebird company, which was based in Germany earlier, they have shifted to America now. It is approved officially by FDA for treatment of thalassemia, and some children have got treated also with that also. But one very big जो है cost, prohibitive factor. What is
Also,
the approximate
yes, sir.
cost? You will be surprised. It is $2.5 million, about 25 crores. This treatment costs. So nobody on the means at least from our part of the world can afford it. So they are trying to invent more, means rather I'll say easier way to send this corrected gene inside. Then gene
Yes, sir.
editing, defective gene, you stimulate that defective gene.
Yes, sir. And
BCL11A you have mentioned here. This actually suppresses the fetal hemoglobin production
yes, sir.
gene. So when
Yes,
you
sir.
suppress it, the gene expression, fetal hemoglobin will start
Increase.
increase. Then
Yes,
there
sir.
is less mismatching of the alpha and beta
Alpha
chain.
and the
You
beta.
know,
Yes, sir.
basically the defect in thalassemia is
Excess of
mismatching
alpha
of the
production.
alpha
Yes, sir.
production. So it is like gene editing. It's a newer concept, but hopefully it will come up. Next,
Yes, sir. So,
Ex- or
we have luspatercept,
luspatercept.
which is
Yes.
basically it will bind to the TGF beta superfamily ligands and it will block the SMAD2/3 signaling.
In
So
simple
that will
words, इतना ज्यादा डिटेल में पढ़ने की कोई जरूरत नहीं, सिंपल में रखो.
mature
This is
RBC.
yes,
Yes,
RBC
sir.
maturing agent.
Yes,
It
sir.
helps in maturation of the RBC. बस.
RBCs. Yes, sir.
But the problem क्या है इसकी? How it is given? 1 milligram per kg subcutaneous. It's available in India as Zintiglo. No, it's available as, I'm
Um,
for, I'm forgetting the name. In India, it is available for a long time, but we have not used it for a long time because of its cost and not a very good effect. See, it generally does not prevent blood transfusion. It doesn't
mm,
make you transfusion free. It increases the transfusion interval. You have written yourself in very big letters, 33% reduction of transfusion.
reduction.
But at what cost? What is the cost of 25 milligram vial of this luspatercept?
So,
It is 33,000.
okay.
Let me check how can I forget Indian name? Reblozyl. Oh,
Yes, sir.
Reblozyl. It is available as Reblozyl. So it was incidentally detected. See, they were for post-measles, post-menopausal ladies. They were testing a sister product of this luspatercept that was called sotatercept. When they were
Okay.
trying that, they found that their hemoglobin increased. Nowadays, it is not used for osteoporosis. They were in fact trying this drug for osteoporosis, sotatercept and luspatercept. Then both these drugs were tried in thalassemia and other conditions with low hemoglobin to increase the hemoglobin level. And
Yes, sir.
luspater uh, just went ahead in the race. So trials with sotatercept were stopped. So luspatercept came to the market. But the only problem is injection is given every 3 weeks. And for a 50 kg person, the injection would cost 60,000, 70,000. Though company has now reduced it to almost half the price, but it is still very okay. Next.
And then there is another drug which has
Yeah, this is a recent
recently
addition.
been
It was
used.
approved. When was it approved? Tell me.
Sir, I think last
December
month.
last year, December 25. This is
December.
the latest,
Yes, sir.
latest addition to the treatment of thalassemia, mitapivat.
With
It is the
Apivet.
only oral drug. Rest
Yes,
all
sir.
luspatercept and all those are injectables. This is the
Yes, sir.
only drug which is known to improve the hemoglobin,
Um,
and basically it is
RBC
a,
span.
yes,
Inhibitor
lifespan
of
it
the
increases.
pyruvate kinase. Yes, sir.
Yeah, I think it is activator of the pyruvate kinase. So
Yes, sir.
it is also used for pyruvate kinase deficiency also.
Yes,
But
sir.
again, it's a very expensive drug so far.
Yes, sir.
Let's hope it price reduces and then we'll see. Okay. So the key things are you are written clearly. Very nice. And I think we can stop here. Or if anybody has any question, you can write in the chat box. Let me see the chat box. Or if you can, you want to ask anything? Vitamin D is given only on transfusion day or monthly su- supplement given? Vitamin D should be given ideally daily as 1000 international unit to all children with thalassemia. But since that preparation is not easily available, so you can give 160,000 sachet every 2 months. That will come to 1000 unit every day.
Every day.
Yes. And anything else? Anybody wants to ask? You want to ask anything, Vasudha?
No, sir.
You want and add anything to your good slides you have made? Good presentation, but you have to just go through the treatment, more
Yes,
practical
sir.
way of treatment.
Yes, sir.
Okay. Anyway,
Yes, sir.
good, very good preparation, very good slide. You have covered that recent advances very well. I think that is the thing you should know. You may get a
Yes,
short
sir.
note on recent advances in thalassemia. Just 3, 4 things you have to write in that. And the treatment, transfusion therapy and chelation therapy you should know. Okay. And
Okay, sir.
complications like blood transfusion reactions and all that, you should know. Filtration and NAT testing, I have told you. These reactions you can read from the book. It's given nicely in, if you download that book from Thalassemia
Thalassemia
International
International Federation.
Federation site, there is a book available. I
Yes,
think
sir.
last year it came, 2025.
25.
Latest is that TDT, and
Yes, sir.
2023 is NTDT.
Yes, sir.
Okay, chalo, good, very good,
Thank you,
well
sir.
done, well
Thank you,
done.
sir.
Okay,
Thank you.
right, bye bye, good night.